Okay, so it's 6 minutes past 4, so I think it's about time that we get started. So thank you very much, everyone, for joining. I'm Professor Leslie Anderson, a chair in health data science at the University of Aberdeen. And I also have the role of Interdisciplinary Institute Director for Health, Nutrition and Wellbeing at the university. And I think very much like our speaker, Kelvin Jordan, who's joining us today, have an interest in utilising big data and clinical and health data sets in order to answer questions around health and healthcare delivery. So the CHI International Alliances meetings that you're attending today are a set of series of meetings with regards to speakers from across Canada, the UK and Australia. And they're hosted by the Centre for Health Informatics at the University of Calgary Department of Global Affairs. And this platform is aimed at trying to enhance knowledge, enabling collaborations and opening up opportunities for co-supervision of students. And there's a plan to host faculty speakers once per month, and we're trying to do that across each of the different jurisdictions. And I have the pleasure today in introducing Professor Kelvin Jordan, who is a professor of biostats, the School of Medicine at Keele University in the UK. And he was the original lead of the Keele Health and Care Data Research Network, and is also Deputy Director of Keele's Data Strategy Digital Society Institute. I should leave this for you to introduce yourself, Kelvin, but his research, as I said, focuses on the health and analysis of electronic health record data, utilising advanced statistical and epidemiological methods with an interest in understanding burden risk management of prognosis of health conditions and symptoms in order to be able to aid clinical decision making and improving clinical outcomes. So I'm super excited to hear about your work today. And the title of the talk is Cardiovascular Risk Protection Models Using Electronic Health Records. So over to you, Kelvin. Thank you very much indeed.
Right, thank you, Leslie, and I'll just share my screen. Okay, so hopefully
we can see that.
Screen.
Thank you.
Great. So thanks very much for the introduction, Leslie, and thanks very much for inviting me to talk today. As Leslie says, I'm in the School of Medicine at Keele University in the UK. So for those of you who are unaware where Keele it is, it's about halfway between Birmingham and Manchester. The building you can see on the picture here is Keele Hall, which was built in about 1580. This is probably the most scenic part of the Keele campus. The rest of the campus isn't quite as scenic as this, I'm afraid. Just to give a bit more background, as you mentioned, I'm part of the Keele Health and Care Data Research Network, which is quite a long title, but basically it's a group of about 50 to 60 researchers here in Keele in the School of Medicine, methodologists and clinicians who are all interested in using healthcare data in research. So that includes national UK data as well as regional and international data sets. And we do that across a whole range of conditions: cardiovascular, musculoskeletal, mental health, and so on. I also lead the biostatistics team here in the School of Medicine, and we have about 20 statisticians with expertise ranging from kind of randomized controlled trials to prognostic studies, analysis of big data, and also kind of meta-analysis and IPD as well. So a whole range of expertise. And obviously we have a group of postgraduate students as well. And the final group I just want to mention is the Keele Digital Society Institute, which is a cross-university institute, which incorporates all things digital and kind of links into kind of local public and private institutions to look at kind of digital components of life. And I'm one of the leads of the digital health theme. I'm particularly interested in data science methods within digital health. So very open to collaborations if there's kind of areas that you want to discuss after this meeting. Excuse me. So in terms of what I'm talking about today, essentially based on a study we did a couple of years ago, funded by the British Heart Foundation. It's a collaborative study with Oxford and UCL. and looked at cardiovascular prognosis in patients with undiagnosed chest pain. So what exactly do I mean by sort of undiagnosed chest pain? So every year, about 2% of adults go and see their GP with chest pain. Now, the GP may well send them off for an investigation if they suspect a kind of a severe cardiovascular complaint. But typically what happens is they get recorded with one of three things: angina, a non-coronary reason for the chest pain, such as anxiety, musculoskeletal, respiratory, or it's basically unattributed, there's no diagnosis. The GP has ruled out anything cardiovascular in nature, but isn't quite sure what the reason for the chest pain is. And they basically just record it as chest pain with no kind of underlying reason that they're aware of for that chest pain. And that final group makes up about 2/3 of all people with chest pain. So when you think about 2% of adults consult each year with chest pain, that's quite a big group of people who don't actually get a reason for the chest pain that they're presenting with. What we know from previous research from other groups is that compared to people without chest pain, those who present with chest pain, which isn't cardiovascular but has got no actual attribution, they're actually at increased risk of future cardiovascular disease than those without chest pain. So there is kind of an increased risk in this group for cardiovascular disease. What we've kind of shown in one of our first studies were when you compare this group with unattributed chest pain to those with a non-coronary cause, such as anxiety or musculoskeletal, the patients with unattributed chest pain have an increased risk again compared to that group. So that's displayed by the graph on the right, which shows risk of cardiovascular event in the 10 years after their initial presentation with chest pain. And you can see it's consistently higher for the unattributed chest pain group than those who do actually get a non-coronary cause given for their chest pain. The table below shows that, again, this is quite consistent over 10 years. It does fall a little bit for any cardiovascular and for coronary reasons. It is quite consistent for myocardial infarction. There's no relationship with stroke. So basically what we have here is a group of patients who had increased risk of cardiovascular disease. Although it's kind of a small absolute risk, they still are at an increased risk. And given the size of this population, it isn't really practical or cost effective to kind of throw statins and preventive medication to all this group to try and prevent future cardiovascular disease. So what we might want to do is try and identify those at most risk within this kind of group of patients with unattributed chest pain. So how do we do it? So at the moment, in the UK, GPs have guidelines from the National Institute for Health and Care Excellence, NICE. And one of the guidelines is around cardiovascular disease risk assessment. And I'll just cut a couple of bullet points from their guidance to GPs. The first one being that if they want to kind of work out risk of cardiovascular disease in the next 10 years, they should use a tool called QRisk-free. And if people score more than 10%, so have a 10% risk of cardiovascular disease or more over the next 10 years, they should be offered a lipid-lowering drug, statin, essentially. So the QRisk-free tool is the kind of the recommended tool for use in general practice to assess cardiovascular risk over a 10-year period. So this is what it looks like, and the QRisk-free, and there's actually a QRisk-4, I think, come out now as well, but the QRisk-free is actually embedded in primary care within the UK, so that GPs could, and it can actually be scored based on information within the medical record, so it can be calculated automatically based on that information in the medical record. It was developed by a group who were then in Nottingham and validated, and you can see on the left what kind of risk factors it includes. So it includes social demographics around age, sex, ethnicity, and postcode. So there's a link to deprivation, so the postcode use of deprivation, and also clinical information, so comorbidities such as diabetes and atrial fibrillation, rheumatoid arthritis, and so on. Some other measures around cholesterol, blood pressure, and body mass index. So those are basically the risk factors that are used, and you can actually go online to the QRisk website and work out your own risk of cardiovascular disease based on that information. And if you do that, you basically get an output such as this, which tells you your risk of heart attack or stroke in the next 10 years, so 3.5% in this example. and it compares your risk with someone of the same age, sex, and ethnicity. You can see kind of in the middle, there's one of the, I guess, limitations is that not all the data may be in the primary care record. So when the GP tries to calculate Q risk, all the information may not be there, such as cholesterol or blood pressure or body mass index. And if that's the case, you get the average of someone of your age, sex, and ethnicity. So there's a bit of kind of estimated data in there as well, but potentially it's a tool that's recommended for GPs to use to evaluate the risk of cardiovascular disease in someone. So one of the questions is how much prediction rules or prediction tools such as Q risk are actually used by GPs in the UK. So this was a study by Ban and colleagues from Oxford, where they did a survey in 2014 and 2019 and asked GPs how much they actually use these kind of different cardiovascular clinical prediction tools. And one of them they looked at was Q risk. Back in 2014, it was only at Q risk 2. It's now arrived at Q risk 3. But what you can see is in 2019, there was an increased use and recognition of the cardiovascular prediction rules, and particularly Q risk. So in 2014, about 65% said they used Q risk most or all relevant cases, occasionally or rarely. And that had increased to 96% in 2019. And the majority who did actually use them sort of in most or all relevant cases, or at least said they used them in most or all relevant cases. So it appears that GPs are familiar with these prediction tools that are available for them to use in primary care and do actually use them. The challenge we've got is if we're going to try and use them in patients with chest pain, how well does Q risk 3 actually work in those with unattributed chest pain? Q risk 3 was developed and validated for the general population. And we already know that patients with unattributed, undiagnosed chest pain are at an increased risk of cardiovascular disease than the general population as a whole. So it may well be that the Q risk 3 doesn't actually work in the chest pain population. It hasn't been developed and validated in the chest pain group. So one thing that we wanted to do was to basically test to see whether Q risk 3 actually works in this group, and also whether we can develop a new model which may work better than Q risk 3. Essentially, what we're trying to do, let's say in this study, was develop and validate a prediction model for cardiovascular disease in adults who present to primary care and don't get a diagnosis for the chest pain that they have, and compare the performance of this prediction model to Q risk 3, which, as I say, was developed for use in the general population. And all the details, which I'm going to present briefly now, are in that paper published in the European Journal of Preventive Cardiology. So essentially, we've used the Clinical Practice Research Data Link, CPRD, which is a UK primary care database. It covers about 25% of the UK population and is representative to the UK population of things like age, sex, ethnicity, and deprivation. And it includes all the information recorded in primary care when someone consults, so the reason for consultations, prescriptions, referrals, tests, and imaging that may be requested by primary care. It also has a linkage to hospital inpatient data, so secondary care data, mortality and cause of death, and also neighbourhood level deprivation data based on a person's postcode. So we use the linkages available within CPRD to do the study. CPRD has two primary care data sets, Aurum and Gold, and they're differentiated by the software that practices use. So practices which use EMIS Web contribute to CPRD Aurum, and practices which use Vision software contribute to CPRD Gold. And CPRD Aurum covers at the moment about 1,400, or at the time of the study, about 1,400 general practices, which is about 40 million ever registered patients, and about 16 million currently registered patients. So it is a very sizable database. CPRD Gold is a little bit smaller, covering around 900 plus general practices. And so we developed a new model using CPRD Aurum and validated it within CPRD Gold. So validate it in a different data set to the one we developed it in. So in terms of the study population, so we basically had a criteria that people had to be aged 18 years and over, and had a first primary care record of unattributed chest pain. So a record coded, for example, as just as chest pain between 2002 and 2018. We excluded people who had a kind of a cause of the chest pain. So if it's recorded as musculoskeletal chest pain, we excluded them. We also excluded anybody with a prior history of cardiovascular disease, or if they had a record of cardiovascular disease in the 6 months after their initial consultation for chest pain. And we then followed up people from 6 months after that consultation for chest pain. We used the 6 months as a diagnostic window on the basis that GPs may sometimes record chest pain while they're still doing kind of investigations to evaluate the cause. So we basically use that 6 months window to get rid of anybody who may have a cardiovascular disease or another reason recorded for their chest pain. In the UK, patients can get sent off to rapid access chest pain clinics. So we thought 6 months was a reasonable time to ensure that any diagnosis related to that index chest pain had been recorded and made into the records. The outcome was basically a recorded cardiovascular disease event in follow-up, and we kind of followed people up for up to 10 years and censored at the time where they kind of practiced their records ended, or they had a cardiovascular event, or they died. In terms of the definition of cardiovascular disease, so these are all the kind of conditions defined in our outcome. And this is very much based on the definition that Q-risk-free uses. So you basically use the same definition as them. You can see it includes stroke as well as kind of coronary conditions within cardiovascular disease. We did look separately at coronary, but just for purposes of today, I'm going to concentrate on the overall definition of cardiovascular disease. In terms of sample size, so CPRD Aura was a big database. We had 374,917 people who fulfilled our criteria. So these are 374,000 people who presented with chest pain and didn't get a diagnosis and had no prior cardiovascular event. And during follow-up, the event rate was 19.3 per 1,000 person years. To validate the model in CPRD Gold, we had 226,000 patients with a CVD event rate just slightly lower than for Aurum. Comparing the baseline characteristics between Aurum and Gold, they're actually very similar. So it was a very similar group we had in Gold as compared to Aurum. So how do we develop the model? So first of all, we obviously had to decide what factors to include in the prediction model. We did that through consensus of the study teams. That included kind of cardiovascular researchers and a consultant team, cardiovascular, statisticians, methodologists, GPs, health informatics people as well. So a whole group of people went into considering what risk factors we needed to include. Because this is based on primary care data, there need to be risk factors which were recorded within primary care. So we included all those factors included in Q-risk-free, which I showed you earlier. We also added in alternative explanations for chest pain, such as anxiety or musculoskeletal chest pain. And we also included other comorbidities we thought may be predictive of cardiovascular disease, which weren't included in Q-risk-free. So it's quite a big set of risk factors, which I'll come back to shortly. In terms of analysis, we used flexible parametric survival models to look at risk over 10 years and to develop our kind of prediction model. We did some sensitivity analysis, so we basically followed the Q-risk-free approach. If someone had missing data on things like cholesterol or body mass index or blood pressure, and used the kind of age, sex, ethnicity mean for that person. But we did also look at multiple imputation. We did do a sensitivity analysis where we used multiple imputation. We did do a separate study where we looked at kind of machine learning methods rather than kind of more traditional stats approaches to survival analysis. And And we're also aware that some of this group, and I'll come back to this later, actually were already on statins, so they're in medication. So we did do a sensitivity analysis where we restricted to those not already on preventative medication for cardiovascular disease. I'm not going to go into detail about sensitivity analysis because they didn't really make an awful lot of difference to the main results, which I'm going to show you now. So in terms of what models we developed, we actually went through kind of 5 different models. I'm only going to focus on 2 here. So the first one was kind of the really basic reduced a priori selected key factors. So these were risk factors we thought were definitely going to be important in measuring risk of cardiovascular disease, decided by looking at what's NQ risk-free, but also by consensus of our study team. So age, sex, ethnicity, neighborhood deprivation, smoking status, type 1 and type 2 diabetes, family history of cardiovascular disease, chronic kidney disease, atrial fibrillation, hypertension. That's treated hypertension, so on medication for the hypertension, and body mass index. The full model was kind of our deluxe, kind of all singing, all dancing model. It was the 5th model where we included all the risk factors, 23 of them. We looked at fractional polynomials for variables which were measured on a continuous scale, such as age. We included interactions, particularly interactions with age and sex. And we also did a stepwise selection to decide which factors were important to go into the final prediction model and which interactions we should include. Models 2 and 4 were kind of step ups from the reduced model to the full model. So we kind of divert the model progressively, making it more complex each time. But so I'm going to focus on the first and particularly the last model here. So once we developed the model in CPRD Aurum, we validated it in CPRD Gold. And so we used kind of traditional methods of validation. So we looked at discrimination, which essentially looks at how well the prediction model discriminates between those and those who don't get cardiovascular disease. So essentially we use C-statistical area under the curve. Values closer to 1 are better, and anything above 0.75 is kind of a good validation, a good model. We also looked at calibration, which basically compares expected and observed probabilities of cardiovascular disease. So we looked at the ratio of expected and observed probability of cardiovascular disease with an optimal value of 1. We looked at the calibration slope, where again we're looking for a value closest to 1 as possible. And we also produced calibration plots, which essentially are plots of the observed and expected probabilities for each tenth of predicted risk. And I'll show you some of those plots in a second. So those were our kind of measures of validation once we developed the model in Aurum and validated it in Gold. In terms of the risk factors, just to show you kind of which were the important risk factors, these are just some of them picked out, not all 23, I don't think. Cholesterol and age are measured on a continuous scale, which is why their confidence intervals are small. You can see that type 1 diabetes is a strong risk factor for cardiovascular disease. So it's kind of the normal suspects: atrial fibrillation, hypertension, smoking, male sex, being in more deprived areas. They're all very strongly associated with future cardiovascular disease. Perhaps the surprising one was chronic kidney disease, which in risk-free and other papers has shown a strong association with risk of cardiovascular disease. But in our study wasn't predictive at all, to be honest. It was kind of hazard ratio of 1. So that was a bit of a surprise, perhaps, but the rest of the factors we found were as we kind of expected. So these are the model coefficients. I'm not expecting you to look at this in any detail, but just to show you kind of how we developed the full and reduced model. So on the left-hand side, you can see at the top, you can see how we kind of transformed age, for example, and on the right-hand side, how we transformed cholesterol about halfway down the right-hand side. And the key interactions at the bottom on the right-hand side were things like sex and age, sex and ethnicity, and sex with some of the comorbidities, atrial fibrillation, hypertension, and BMI, and respiratory conditions. So that's basically the model that was developed that we then went on to validate within the GOLD data set. So how well did the model do? So this is external validation in CPRD Gold. I say, if you remember, we had the reduced model, which is the smaller model of a priori selected risk factors, and the full model, which kind of has the all singing and all dancing model. And what you can see is actually the reduced model and the full model are actually very comparable. You didn't get much more benefit from doing the full model than you got from doing the reduced model. The C statistic, the area under curve, was 0.8, so that was above our kind of hopeful level of 0.75, so that was good. Calibration slope was very close to 1, which is also good, and the ratio of expected to observed event probabilities was also very close to 1. So that was basically showing that our new model seemed to be kind of well validated and worked well in the CPRD Gold set and CPRD Gold data set. How did that compare to Q-risk-free? Well, we kind of took the Q-risk-free model and also applied it to the data, and then tried to validate Q-risk-free in CPRD Gold. You can see the C statistic, the Q-risk-free, is actually very similar to our new model, so just fractionally below 0.8, so still very good discrimination. The calibration for Q-risk-free was poor. See, the calibration slope was 0.767, and the ratio of expected to observe event probabilities was 0.493, and we really need that to be as close to 1 as possible. So Q-risk-free didn't perform well in terms of calibration. And the interpretation of that is Q-risk-free is underestimating the risk in this group of patients with chest pain. And it's kind of what we expected, because Q-risk-free was developed in the general population who have a lower absolute level of risk anyway, compared to our chest pain group. We were kind of expecting Q-risk-free to underestimate the risk within our chest pain group. So these are the calibration plots. So if you're not aware what calibration plots is, essentially what you want is those green dots to fall on the kind of dashed blue line, which goes kind of at 45 degrees. On the left-hand side is our new developed full model. On the right-hand side is Q-risk-free. So you can see that our full model does actually perform very well. Those green dots are very much lying on the blue dotted line, as we would hope, which kind of shows that observed and expected probabilities are actually very similar for each of those deciles. Q-risk-free, you can see the green dots are to the left of the blue dashed line, and as the calibration statistics I showed you on the previous slide suggested, Q-risk-free is underestimating the risk. So the observed risk is actually much higher than the expected risk that we get from Q-risk-free. So if GPs use Q-risk-free in this group, they would be underestimating the risk of cardiovascular disease in this group of patients. And just to put that into numbers, so as mentioned before, NICE basically recommends anybody with a risk score of 10% or more to get statins. Our new model suggested about half our group, 53%, had a risk of 10% or more. Q-risk-free only suggested about 29%, or about a third had a CVD risk of 10% or more. So again, showing that Q-risk-free is actually underestimating the risk in this population. Just to look at it the other way, how many patients actually went from a score of more than 10% on Q-risk-free to less than 10% on our new model. It's actually a very small group, only 188 patients, 0.1%, actually reduced their risk in the new model compared to Q-risk-free. So again, kind of underline the fact that Q-risk-free is really underestimating risk in this group of chest pain patients. So carrying on trying to validate our new model, so it's important to make sure that it works in different subgroups as well. So looking at it by sex, you can see that basically the calibration works well, and discrimination was similar in both males and females. So there didn't seem to be any kind of better or worse performance based on sex for our new model. We looked at it by deprivation, and here we just got the least deprived quintile and the most deprived quintile. And again, it seems to work just as well in the most deprived as it does in the least deprived quintile. And that was similar across all the quintiles of deprivation. So again, it seemed to be working pretty well. And it wasn't kind of failing to perform based on deprivation. We can also look at it by geographical region. So in CPID, there are essentially 10 broad geographical regions, which split signaled up essentially into south, southwest, north, etc. These are the geographical regions and testing the model in each of those regions. Some of the numbers got a little bit smaller, which is why the confidence intervals here for the calibration slopes are a bit wider. But essentially, it seemed to be forming reasonably well across all the geographical regions, both north and south. So that was kind of reassuring as well that there was no kind of north-south divide or anything in terms of the performance of our new model. So we did actually take a step further and just looked at kind of the modifiable risk factors and tried to estimate, what would happen if some of these risk factors were removed. So the model suggested in our entire group of unattributed chest pain patients a mean average 10-year risk of cardiovascular disease around 17.4%. If we kind of looked at everybody who was obese and said, actually, what if everybody who was obese was actually overweight? You could reduce that 17.4% to 16.9%. So a slight reduction in the population level of cardiovascular risk. If everybody who was currently smoking became ex-smokers, then you could potentially reduce the risk to 16.5%. And if you did both of those things, so everybody who was obese went to overweight, and everybody who was current smoker went to ex-smoker, and the kind of overall average risk in everybody with unattributed chest pain fell to 16%. So we had about 1.5% drop. The biggest impact, not surprisingly though, is in those who are both obese and currently smoke. So at the moment, if you're obese and currently smoke, the average risk is around 21.7% for a future cardiovascular event. That would actually drop to 15.6% if you kind of reduced to overweight and to ex-smoker. So quite a big impact in those patients with those two kind of really key risk factors in terms of how their cardiovascular disease risk may potentially change. So just thinking about some of the conclusions. So what we've shown, I think, is that the Q risk-free obviously works very well in the general population, but it does underestimate the risk in our group of more at-risk population. And there isn't a risk factor of chest pain within the Q risk-free. And I suspect that's kind of a more general statement about prediction tools which are derived in the general population, that they may actually underestimate risk in those groups which are basically more at risk. It's interesting that our kind of new model performed really well, but the simpler model with just 5 or 6 kind of key risk factors was as good as the full deluxe model. And I guess it comes down to how you might use a model like this in practice. If it's going to go within a GP records, then it doesn't matter if it's a really complex model because it'll all be automated and calculated on the spot. But if it's not going to be automated, then a simpler model may actually be all you need. The next step, of course, is kind of what's the impact of developing a risk prediction model like this. And just to take a step back, we did actually do another analysis before we did this prediction model, where we essentially took our group of patients with unattributed chest pain and worked out how many of those had a Q risk score of 10% or more. So they may not have actually been measured by the GP. We basically used the medical records to work out their Q risk score. But then we said, out of all those who had a Q risk score of 10% or more, what is the current management? What is the management in the 6 months after their index chest pain complaint? So the blue line shows that less than half are actually sent for an investigation. That's slightly gone up over time, but it's still less than half have been sent for a cardiovascular investigation in the 6 months after their initial chest pain. And the percentage of people who get a lipid-lowering drug, basically a statin, is below 40%. So if you remember, the NICE guidance is anybody with a Q risk score over 10% should be offered a statin, only about 40% of our group. actually were getting a statin. And in actual fact, most of these people were already on a statin. It wasn't a new statin. It was kind of they already been prescribed this before their chest pain episode. And the green line down at the bottom is basically removes everybody who was already on a statin before they consulted for chest pain. It just looked at those who kind of were not on statins, and only about 10% of these patients were newly prescribed a statin after their chest pain presentation. So basically, it may well be that GPs aren't using the Q risk model to evaluate the risk, but it also shows that even patients kind of perhaps at the most risk of cardiovascular disease in the future aren't getting preventative medication that perhaps they might need. And I think there's kind of evidence that even if GPs use some of these kind of prediction tools, not just in cardiovascular disease, but in other areas, it doesn't always change management. And I think talking to GPs, what they say is basically there's an overload of clinical prediction tools now in primary care, not just cardiovascular, but diabetes, fracture, osteoporosis, you name it, there's probably a clinical prediction tool that will kind of spring up for them to use potentially. And so there is kind of an overload of clinical prediction tools in primary care. So I think the GPs within our team, the ones we've talked to, are saying to us they don't actually want a new model within their kind of primary care for them to use. But it's more about recognition that there are kind of a small number of key risk factors, which I think was highlighted by our kind of a smaller first model, reduced model, that could be used and basically say if they've got kind of one or two of these kind of key risk predictors or risk factors, then they should be encouraged to kind of improve lifestyle behaviors related to diet, physical activity, smoking, and potentially think about prescribing of lipid lowering and other preventative medication. Because I think what's came out very clearly was there are kind of a small number of risk factors which are very important in this group. So I'm going to leave it there. Just a few disclosures that I need to state, and I'll basically leave you the links with the papers, and also if you're interested in kind of some of the groups that we work with, the links to the web pages there. I can't promise they're all up to date, but this should give you some information. Okay, thanks very much for listening.
That's great, super interesting, and thank you for the presentation. Are you happy for the slides to be shared?
Yeah, that's fine. Yes, yeah,
okay,
I can send them to you.
Yeah, we can maybe get those shared if folk would like to see those and get access to the DOIs, etc. for the papers. I think that would be really helpful. I'm going to open for questions. Unfortunately, the recording and transcription, let me just delete that, is hiding a lot of the people. Maybe just keep the slides up in case you want to go back to highlight some of the slides with the questions. Has anybody got a question? If not, I think I have 4. So Mintu, do you want to ask the first one, please? Just introduce yourself whenever you're asking questions so that we know who you are and where you're from. So Mintu, I don't know whether your mic is off at the moment. Don't know whether there's issues with regards to getting in, but maybe in the meantime, while Mintu gets himself sorted, to ask the question. Just in relation to the sort of the last bit that you were having a conversation there about general practitioners saying, you know, there's so many of these sort of risk prediction tools, whether or not they're able to utilize them, whether they know that they're there, whether they would think to utilize those. I've had similar questions over some of the work that I'm interested in and looking at automation, I suppose, of those tools, just providing almost whenever a doctor comes in and starts typing in, these are the symptoms that the individual is presenting with, does something automatically come up on their screen to say suspicion or not? What are your thoughts around that, about using sort of or thinking about restructuring some of the systems and working with the companies that provide the digital systems that the general practitioners are utilising to lead to automation within that system to assist or aid GPs.
Yeah, I mean, I think it's an interesting idea. I think talking to GPs, they do have a bit of a backlash against things popping up on their screen when they're trying to enter information. You know, if you listen to them, it sounds like things are popping up left, right, and centre. But I mean, some of these are kind of implemented within. So key risk free is kind of implemented within the system as it is. So you should be able to get it quite automatically. I mean, I guess it's the next step is not just GPs recognizing that they can use these tools, but what they do if there is an increased risk. Yeah, which is probably clear, I guess, for cardiovascular disease, and maybe less clear, I guess, for other conditions. I think GPs will also quite rightly say that, you know, they'll treat each patient individually. So the key risk free is kind of informative, or the risk tool is informative.
Yes.
And you have to take into account other considerations. But I think there's got to be a halfway house. I think the automated may be one way of doing it, because I think these are useful and can be clinically useful for GPs. Yes. It's just getting to that stage where we kind of, that it's an aid to them rather than they consider it a hindrance.
Yeah, and I think that's the key thing, isn't it? And it's working with general practitioners to look at how can we facilitate aids to assist them in primary care, probably at the beginning of looking at developing tools or how those might be implemented into practice. I suppose a lot of the work I do is in that sort of implementation science of how do we implement these things into clinical practice in a way that works. So that's certainly something that is of interest. I think
so I might need to talk to you a bit about this then.
Well, people don't tend to want to talk to me because I talk all about how do we evaluate this in an appropriate way, and usually it adds to additional work that's needed. But yes, I think implementing into practice is super challenging in a way that's effective.
I think sorry, just to add.
Yeah, go ahead.
Just to add, I think the next stage of this study is actually to work out how to kind of best implement this type of thing. So not necessarily the model, but how to kind of get GPs to kind of improve the management of people with chest pain like this.
Yeah.
So that is the next stage that we're considering at the moment.
That's good. And I think we've done some work with general practitioners, and it's incredibly challenging to work with GPs, I think, because they're so overburdened with work and with waiting lists, etc. But yeah, certainly something to consider. And I think as well, for those that are thinking about and developing tools, having those conversations with stakeholders really early in the process of your analysis is super helpful, because you know, they may say, well, actually I would never even consider taking that type of data into consideration because we don't think that it's robustly collected or annotated within the data systems, etc. So that conversation early is really helpful. All right, Mintu, can you come in now? I think you should be able to. Yay, great, thank you.
So yeah, it's quite nice presentations. Thank you so much. So, well, I have a couple of questions regarding, so why did you use that, or the rationale behind using the parametric model rather than Cox proportional hazard? And of course, I think you mentioned about some machine learning based models also you explored. Of course, maybe some details, or at least what sort of models. And the other thing was, do you have multiple observation on the same patient? And in that case, did you have some sort of those frailty structure incorporated on that?
Yeah, so we use flexible parametric because I think it gives you a better kind of baseline hazard than the Cox proportional model, and also allows us kind of to cater for the kind of the proportional hazards assumption a bit better than perhaps the Cox model might do. Sorry, your other questions. Sorry, the machine learning. So I mean, to be fair to the machine learning, we didn't. When we originally started, we wanted to kind of do almost like a big data dive and just throw every variable in just to see what came out. You know, the full kind of machine learning, if you like, works. In the end, we kind of only restricted it to the kind of what we thought were the key face value variables that you've seen here. So I'm not surprised the machine learning didn't really show any improvements compared to our current models. I mean, we did try a range of machine learning techniques, which was done by someone, not me, so I'm just trying to remember what they were. But I might have to come back to you on that one.
Mm-hmm.
Yeah. Sorry, what was the final question?
It's about you have the multiple observations on the same patient.
Oh, so yeah. No, so we only took the kind of the index presentation. So this is kind of people with chest pain, their first visit for chest pain. Yeah, so we used, so the machine learning kind of used things like, I just found the notes now, so penalized Cox models, random survival forests. We used about 4 different types of approaches to machine learning to see what worked. And to be honest, they gave very similar sort of validation metrics as to what I showed you here.
Yeah, that means the standard parametric, this flexible parametric model is almost, in fact, sometimes better than their machine learning model. And particularly, I was quite, all those calibration slope looks almost like magical. And it seems to be so beautiful. So how did you get, what sort of things that you approach to the modeling that you got so beautiful plots?
So we did, I didn't take you through the whole steps, but we did kind of look at kind of different relationships, particularly for the continuous variables. So we didn't assume kind of linear. We looked at fractional polynomials. We did quite intense assessment of things like interactions to see whether that would improve the models. I mean, yeah, we were pleasantly surprised by how well the model worked. I mean, the Q-risk-free works very well as well in the general population, so it wasn't perhaps a surprise. The alternative might have been to kind of almost recalibrate the Q-risk-free to see whether we could just use that model but slightly recalibrate it to work in this group. But we wanted to include other potential risk factors such as alternative explanations for chest pain, which weren't in Q-risk-free, which might actually improve the model fit. I mean, I guess we still need to test it further, so perhaps in another primary care data set or in perhaps more recent data, it'd be nice to validate it further.
Thank you. Thanks very much.
That's great. Actually, that's what I was just going to ask. Have you tried validating it, or is the intention to try validating it in the Q research database, which the Q-risk-3 was developed within? And or did you test the Q-risk-3 performance within the 2 CPRD data sets available, and how did you see that perform?
Yeah, so we did. So we haven't tested in Q-risk-free. I mean, the Q-risk-free should be quite similar to CPRD Aurum, because it's basically based on the EMIS practices, which is what Aurum is as well. So you would hope that it would give similar results. It should be the same data. And I know there have been papers which have tested Q-risk in CPRD as well, and they seem to have shown kind of strong validation in the general population. So what we did, we did actually apply Q-risk-free to both CPRD Aurum and CPRD Gold, and it was quite similar in Gold and Aurum in terms of its performance. So the calibration plot here is CPRD Gold, but it was similar in Aurum as well, so it didn't really matter which database we used.
Yeah, it would certainly be interesting trialing that back just to see how your model performs in the Q research database. I suppose the challenge with these is always around the data structures, etc., isn't it? And how that may impact then on model performance. And we do a lot of work on sort of AI evaluations, and we certainly see huge variability clinical site to clinical site. So it was nice to see that your model wasn't being heavily influenced by the region within the UK that the data was coming from. So that was nice to see that sort of more generalizable aspect of the model that's been developed.
Yeah, I think the challenge is these prediction models is, as you say, it's what's recorded in primary care. So there's lots of models which are supposed to be based on primary care data, but it does kind of rely on good recording of the risk factors. And there was missing data. There was some missing data for MBMI, for example, but it is improving. In smoking again, there's some missing data, but it is improving.
We are seeing, yes, we're seeing more general practices recording that information now, but you know, I always wonder how well that's recorded and how well individuals are happy to tell their GP about the amount that they smoke, etc., or whether they're smokers or not. So I think a lot of it, there is, you know, that the level of integrity of data can certainly differ and can differ between different populations and different subgroups of the population as well, I think.
I think you're right, and I think certainly ethnicity is another variable which I think needs to be recorded better, because there's an assumption that these models work equally as well across different ethnic groups.
Absolutely. And I think in Scotland now, the breast screening programme, for example, we're bringing ethnicity into that to be recorded at each breast screening appointment as part of a large trial that we're doing, because of the lack of strong ethnic data capture within the healthcare system. But you're right, I think that's incredibly important, because we know that there's big variations with regards to risk profiles for different ethnic subgroups for cardiovascular disease and for other diseases as well.
No, you're right, and I think that has been one of the, maybe not criticisms, but one of the challenges for, I guess, all the prediction models that tend to be in general practice.
Do we have any other questions from people on the call? I don't know whether they can ask questions because their system, I think everybody's allowed to unmute. If you have a question, please feel free to do that or to put it in the chat. One of the other questions that I had, if you could just go through to the slide where you were looking at the modelling on the basis of reduction in overweight or obesity and also the smoking. Just interested in the reduction in obesity and overweight collectively, was at a lower level than the two independently. Have you any thoughts around why that might be?
No, I suspect that potentially, I guess, for those who are obese and currently smoke, those are the two key risk factors that they may be having. I mean, there is, you know, I mean, I think you have to take this with a slight measure of caution, because it's, you know, it's slightly different saying that we will have this reduction in risk, but it's not been proved. It's, you know, this is kind of, you know, potentially this is what we could reach at. No, but I think I suspect it's the people obese and currently smoke. Those are the kind of the two key risk factors which are driving their risk, perhaps, maybe.
Yeah, I just wasn't sure whether it's whether you were looking at modelling not in individuals who were both, but in either or, overweight or smoking. Just the way it's written there, it said all obesity, overweight, and all current to ex-smoker. Are they combined, or is that individuals, you know, reducing obesity and smoking in an individual rather than across the board for both?
Yeah, so the 16% is basically, if you did that, if you removed, if everybody who's obese went to overweight, and similarly the current to ex-smokers, that would include people who just were current smokers but not obese.
Yes.
And they would go down to ex-smoker, and similarly those who are obese but didn't smoke.
Yes.
And that's at the kind of the full population level, whereas the bottom one is just in those who are obese and they currently smoke.
Okay, so it was just, I think, just the wording of that.
Yeah.
That was what I was trying to get at, yes. Because I would expect that if it was either or, then it would be slightly lower or maybe a slightly higher percentage.
Yeah.
Okay, do we have any other questions? Because we've reached 5 o'clock. That was very quick, running through all of those points that you've highlighted today. Is there anything else from the panel that are attending? We've got a quiet group today. Well, thank you very much indeed for coming and joining this session. This session is recorded and will be made available to individuals at all three institutions across Canada, Australia, and the University of Aberdeen. And we retain those on the system so that individuals can go in and see those when required. Unfortunately, due to the timings, one group is probably midway through the middle of the night. I did wonder one morning that I woke up at 3 o'clock, should I jump on one of the calls? But I think that it's really helpful. And I'm sure certainly others on the call as well would be interested in learning more. And I think it would be helpful. I'm just seeing that Sharon Gordon, who works with us in the University of Aberdeen, is typing. But I certainly think it would be interesting to have some further conversations. In Scotland, we have the sort of research databases availability that hasn't included general practice data. But in the Grampian Data Safe Haven, we're hoping to have general practice data coming in over the next couple of years.
Okay.
And that'll be linked and available along with the secondary care data. So that's maybe another instance or area that we could test your algorithm in the future.
Now, that would be great. And I'm very happy to take any questions. I'll add my email address to the presentation. So feel free to drop me a line if you want to.
That would be great. Thank you very much, everyone.
Great.
I hope you have a sunny afternoon if you're in the UK.
Thanks very much.
Thank you. Bye-bye.
Thanks.